Hello and welcome to the presentation, End-of-Life Symptom Management for the Patient with Amyotrophic Lateral Sclerosis, ALS, a guide for hospice and palliative care professionals. I'm Ileane Mindel, Manager of Community Education for the Les Turner ALS Foundation. So today we're going to talk about the connection between the Les Turner ALS Foundation as the leader in comprehensive ALS care in Chicagoland, which covers the territory from the Wisconsin border to Northwest Indiana and south, as far south as Kankakee, Illinois. The Les Turner ALS Foundation Family, we have been in existence for over the past 40 years. We've built a local community that feels like a family. Together, we encourage and empower each other throughout our journey with the disease and beyond. We support families, so our title of this slide is Supporting Families, and here is a quote from the spouse of a person with ALS. People with ALS are known as pals. So today I'll read her quote. "We would have been lost without the direction given by your amazing team. Thank you all you did to help us better manage this life-changing illness. You are a fantastic group. I feel so fortunate to have had all of your guidance, love, and support." And that's from Janet, spouse of a person with ALS. So what we offer in our support of families is psychological support, end-of-life support, family support. So our support services, we provide a personalized approach to treatment with care, preparing people living with ALS to navigate their difficult journey and support them each step of the way. Some of the services we offer: home and community services. Our team visits, our team, which is comprised of nurses and social workers and therapists, make home visits. And the home could be their home, nursing home, hospital, or assisted living. We provide augmented communication services, equipment grants, respite grants, transportation grants, support group meetings. Our support services are, as I said, home visits by ALS support service coordinators, telephone, email, and referral support, enhance the continuity of care between clinic visits. So that means our support services team visits the patient and their loved ones between the clinic visits. Provide ongoing disease education and address specific concerns, provide practical information on quality of life and daily living, evaluate the home environment for safety, adaptations, and equipment needs, facilitate communication between patient family members and healthcare team, education regarding disability, Medicare, Medicaid, private insurance, and other financial options. Guide access to care through the state programs, caregiver services, and explore additional means to maximize assistance. Assist with advanced directives, including living wills, medical power of attorney, and other end-of-life issues. Provide social service counseling and intervention to improve communication and assist in conflict resolution. So on this slide, you'll see a picture of one of my support groups, which is, we have 4 support groups. We provide 4 support groups in the Chicago metropolitan area. Offers peers navigate and manage their people faced with similar challenges, participants of support groups. Understand on a deeper level what other members are feeling and experiencing. Something's wrong. Okay. So we're going to edit that. There was a little bleep there. Okay, so I'll go over that again. People attending support group are faced with similar challenges. Participants of support group understand each other on a deeper level, what other members are feeling and experiencing without the need of explanation. Support groups help members cope better and feel less isolated. So our support groups that we co-facilitate are only co-facilitated by professionals. So each group has a nurse and a social worker as the facilitators. Community education. The foundation offers assistance with care coordination with home health agencies, hospices, and other community organizations. We conduct in-service education for home health agencies, hospice, case management groups, assisted living facilities, skilled nursing facilities, and nurses organizations. Provide general disease education to employers, schools, and other community organizations. On this chart, you will see how we collaborate, how the Les Turner Foundation collaborates with the Les Turner program at Northwestern. So this is a chart of showing how the Lois and Solia ALS Clinic, the research labs, the education component works closely with the Les Turner ALS Foundation and our support services team. It's a collaborative effort. I always say it takes a village. Multidisciplinary healthcare team. So the team at Northwestern can comprise up to 15 people. And on this chart, you will see it's not just a physician, but it's a neuromuscular neurologist, a specialist, a physiatrist, pulmonologist that specializes in neuromuscular diseases, nurses and medical assistants, clinical dietitians, registered therapists, speech and language pathologists, one of the few programs that has a genetic counselor, social workers, and always the Les Turner ALS Foundation representative. What we'll cover today, we're going to cover an overview of ALS, symptom management, and end-of-life care. What is ALS? ALS, known as amyotrophic lateral sclerosis, is a progressive neuromuscular disorder that involves the degeneration of both upper and lower motor neurons, leading to eventual wasting and atrophy of all voluntary muscles, including muscles that are used for respiration. To have a true diagnosis of ALS, you have to have upper motor neuron and lower motor neuron involvement. Everybody likes facts and figures, so here are some numbers for you. ALS occurs in roughly 1 to 2 per 100,000 people worldwide. That's called the incidence. Prevalence, or people living with ALS in North America, are 5 per 100,000. And these are the latest figures, facts and figures from the CDC. The average life expectancy after symptom onset is 2 to 5 years. Disease progression is unpredictable. That's the daunting part of this disease. People present so differently. Approximately 10% of all people with ALS live more than 10 years. In my practice, I have had patients as young as 13, as old as 98. I have had people live less than 6 months, and I have people who have lived 22 years. Who gets ALS? 90% is sporadic, meaning anybody in the general population can acquire this disease. 10% is familial, and at Northwestern, we see a large amount of familial families because of our research labs, one particular lab that has been following familial families for 30 to 40 years. Slightly more male to female, 1.5 to 1. Incident peaks between 40 and 70, but as I said, we can see patients, and we have a lot of very young patients in their teens up until their 90s. Can occur in people averaging more age 20 through 90. So today we're going to also discuss the National ALS Registry and their outreach program. The registry is a fairly new program within the CDC, and what they offer are, some of their programs are estimates on how many new cases of ALS are diagnosed each year, how many people are living with ALS, better understanding about who in the population gets ALS, better understand what factors affect the disease, and a research to all causes, possible causes of ALS. They also have a biorepository program, which can come, they have professionals that can come to the homes and to get donated specimens, and that will be donated and worked on for research at the National ALS Biorepository. So that can be, for instance, a specimen can be saliva. veterans in ALS, and these are all new facts and figures. Every patient we see, whether in the clinic, whether at a home visit, whether at a support group, the first thing we ask is, are you a veteran? Have you served? Not necessarily, you don't need to be deployed, but have you served in any branch of the military? So all patients are asked, male or female. ALS among veterans, the prevalence is 4,220, and the incidence is over 1,000. They're from the Veterans Health Administration. They care for only 42% of veterans with ALS. And some people might think 42% is a large number. Personally, I don't think so. And among the many reasons that patients or veterans don't gather or don't attend an ALS clinic at a VA ALS clinic is because they live rurally or they're unaware that this program exists through the VA. So there are many factors that cause their not attending an ALS clinic. And ALS clinics at the VA are regional. Military veterans, regardless of the branch of service they've served, the era in which they have served, or whether they served during a time of peace or a time of war, at a greater risk of dying from ALS than if they had not served in the military. And those reasons are still unknown. Veterans are twice as likely to be diagnosed with ALS as anybody in the general population. In 2008, the Department of Veterans Affairs, the VA, implemented regulations to establish a presumption of service connection for ALS. So in other words, it's considered a military-acquired disease. So what are some of the benefits that PALS, that is a veteran, what are some of the benefits that they can obtain? All healthcare costs, reimbursement for travel. VA can provide transportation to their ALS clinic. No copays for visits, pharmacy or durable medical equipment, preferred scheduling, educational benefits for family, health insurance for family benefits. And what's not on here is also they can receive burial services at a military cemetery. In the state of Illinois, that is the Lincoln Cemetery in Elburn, Illinois. So there are two branches to the VA VBA and the VHA. So the VBA is the benefits. So they have to have eligibility. And what's eligibility for a veteran who has ALS? They will have had to have served 1 year and be honorably discharged. Disability and caregiver compensation, grants for home modifications. They can receive as much as $80,000 for a grant to modify or adapt their home. They can receive a grant to obtain a specialized van. Clinicians can submit paperwork but have no control over VBA and do not have visibility over VBA process. Veterans Healthcare Administration, under this program, they can receive, a veteran who has ALS can receive clinical care and everything ordered by a VA doctor or clinician, medications and supplies from pharmacy that can be delivered to their home. Home health, physical therapy, occupational therapy, speech and language pathology, hospice care, social work, mental health, durable medical equipment, and they can get home health as well. So veteran advocacy organizations, why do we connect to VA veterans advocacy? Because sometimes it can be daunting to get into the VA. So we use, and we are very closely aligned with the Paralyzed Veterans of America. And these organizations assist veterans with establishing their VA benefits. And they navigate that bureaucracy, the process of service connection. They are helping in adjusting disability ratings, assess VA programs, and can actually know which ALS clinic would work best for the veterans who have ALS. And they're the bridge for the clinicians and the veterans to the VBA. So now we're going to talk about clinical features of ALS: weakness, cramping, fasciculation, spasticity, ease of laughing or crying, fatigue, muscular aches aches and pains. It's not a visceral pain like a cancer pain. These are musculoskeletal pains from immobility. How do patients present with this disease? Very often they present the presentation of weakness. Most patients first notice weakness in their extremities, up 32% in their upper extremities and 36% in the lower extremities, just like Lou Gehrig first presented when he could no longer run around the baseball park, run around the bases in Yankee Stadium. About 25% of patients present with speech or swallowing problems, and that's known as bulbar onset ALS, or sometimes diagnosed as bulbar palsy. Breathing is rarely affected. We call that respiratory onset is rarely affected, but it can be, and that it can be the first symptom in absence of other symptoms, but that's rare, and that can only be about 7%. Very often these patients present in the ICU or in the emergency room, and are often trached and vented, sometimes even before they've had a diagnosis. Functions rarely affected, and we try never to say never and never to say always. So functions rarely affected are intellect. But we've been seeing more and more patients presenting with mild to severe cognitive impairment, about 30%. Sensation, vision, bowel or bladder, and sexual. These are rarely affected, but bowel and bladder can slow down because of immobility. Functions never affected are the heart, liver, and kidneys. Rilutec, the first drug, FDA approved drug for ALS in 1995, otherwise known as Riluzole. And the mechanism that works on is it inhibits release of glutamate in the brain. It's a glutamate antagonist, an excess of which can damage and eventually kill nerve cells. Northwestern was heavily involved in that clinical drug trial. It was an international drug trial. And what is the effects of Rilutec? Shown to extend survival and, importantly, if started early in the disease. It does not necessarily improve the symptoms, but may slow them down and will not restore the muscles that have already been affected. And in 2018, a new formulation of this drug, now called Tiglatec, is a liquid formulation, and that's designed specifically for pals who are living with ALS who have swallowing problems or could develop swallowing problems. And it's a thickened liquid formulation that helps deliver the medicine. And very often with patients who are using PEG tubes, it's the ideal way to use this drug. And here's the newest drug, Radicava, otherwise known as Dorama. It came to the United States two years ago, August, and it's the first FDA approved drug that came to the United States without going through clinical trials in the United States. It came to us from Japan, where they showed a 33% slowing of the loss of function based on the ALS-FRS scale. It's an intravenous administration, and as you can see, it's very intense early on. It's 60 milligram daily times 14 days, then 2 weeks off, and drug followed by monthly treatments given 10 days over 14 days, then 2 weeks off. The dosing schedule is repeated every month. And some of the common side effects with this drug are bruising, gait disturbance, headaches, and it's contraindicated for people with sulfite allergies, not sulfa, but sulfite allergies. Nearly all persons with ALS develop symptoms of respiratory insufficiency. The usual cause of death in ALS is related to respiratory failure. Ideally, people with ALS and their loved ones will be carefully educated about this disease, and we're very proud that we offer very intense education to our ALS patients. An ALS patient needs to make a decision regarding choosing or not choosing invasive mechanical ventilation, otherwise known as trachs and vents. And that's one of our strong points. We work very closely in trying to educate our patients and helping them make a choice. Hospice is strongly encouraged for all patients who opt against long-term ventilation. So now continuing to talk about presentations of symptoms. People with ALS may have a variety of onset and symptom presentations. I often say that at the support groups, which I co-facilitate 3, we can have 25 people sitting around the table at a group, and I can go around the room and ask how you've presented, and everybody in that group can have presented differently. And that's the enigma of this disease. The site of onset, along with the speed of progression, varies from person to person. It's very unique. In the latter and end stages of ALS, patients may experience respiratory insufficiency, fatigue, problems with mobility, pain, dysarthria, dysphagia, problems with secretions, involuntary emotion expressive disorder, otherwise known as IEED or pseudobulbar affect, depression, insomnia, and constipation. And these all can be effectively managed to allow the patient to remain comfortable and have a peaceful end of life. We try never to say, there's nothing we can do for you. We always try to say, there is something we can do for you. There is always a plan. Symptom management. Signs and symptoms of respiratory insufficiency are shortness of breath, dyspnea on exertion, especially, and we never realize how we get short of breath when we are speaking, eating, and are doing our activities of daily living. Waking up frequently and interrupted sleep can be a really strong symptom of respiratory insufficiency. Morning headaches, vivid dreams, hallucinations, and confusion. That can be due to the buildup of CO2 overnight while they're sleeping. They could be using BiPAP, VPAP, Trilogy, or Astral, and those are known as bilevel positive airway pressure, otherwise known as non-invasive positive pressure ventilation, NIPPV. Airway clearance treatments can be nebulizer treatments, cough assist treatments, vital cough, and or vest. Something as simple as a bedside fan can help manage respiratory insufficiency or shortness of breath. Changing to a different mask. When you go into a patient's home and you see a patient is having difficulty with their interface or their mask or their nasal pillow, you can't say, well, you just have to get used to that. That's not what we do. There are hundreds of masks, hundreds of interfaces, and that can always be changed and they can be made more comfortable. So changing to a different mask may be helpful for patients for improved desensitization and comfort. Something as simple raising the bed. Let gravity assist. Medications to aid in relaxation like lorazepam or other anxiolytics, and to relieve feelings of air hunger. Something is easily administered is Roxanol or liquid morphine. Important reminders, if you learn nothing else from this education program today, oxygen is contraindicated for the person with ALS unless bled through their BiPAPs or their NIPPVs. ALS patients experience hypoventilation and accumulate carbon dioxide. So the waste of oxygen is carbon dioxide, and the accumulation of this carbon dioxide can be their death knell. So that's why oxygen is contraindicated. Using oxygen without a VPAP, IVAPs, Astrals can result in the buildup of carbon dioxide and CO2 narcosis, which can lead to eventual respiratory failure. Fatigue. Fatigue can be the most daunting experience an ALS patient can suffer. Increasing use and work of breathing for patients with respiratory insufficiency can cause tremendous fatigue. ALS patients use more energy for normal functions such as what we simply take for granted as breathing, eating, speaking, and any physical exertion. Energy conservation is a must. Balancing between rest and activities, just the shower day or doing in their ADLs can be exhausting. Keep in mind that this is a progressive disease. Help is often needed with ADLs, and that assistance of help will change as the patients progress and decline. Aches, pains, cramping, and spasms. Generalized discomfort may be relieved with just something as simple as repositioning, range of motion, stretching, and massage. It's not always a pill that will relieve their discomfort. Stretching and passive range of motion is most important, especially in the morning when they wake up and before they go to bed. Analgesics can be of assistance. Antispasmodics such as baclofen, tizanidine can relieve muscle cramping. Maintaining good hydration can be so important to prevent cramping. Dehydration, because of difficulty in swallowing, can be very complicating. Lorazepam and Tensol drops for laryngospasm. Gabapentin can relieve neuropathic pain, often described as numbness, burning, or a sharp shooting pain. With dysarthria, nothing can be worse than not being able to talk to your loved ones and not being able to call for help or express your needs or communicate with family and friends. There is always another way to communicate. Alternate methods of communication are readily available prior to entering hospice or nursing homes. So we often try to make sure or tune up our patients at clinic, but very often patients are resistant to getting a speech generating device. So often they will come to hospice without having this device, and then remember, the Les Turner Foundation always has a loaner bank of equipment. So we are your connection, and we will always be your connection to assist our pals. Simple tools such as letterboards. We start simple, low, and slow. Simple letterboards, picture boards, flashcards, writing pads, magnadoodles, and the newest generation is called a boogie board, and our patients love their boogie boards. Intermediate devices such as iPads using text-to-speech apps. Speech-generating devices that use eye gate technology is after a patient can no longer use their iPad or their iPhone with an app, when their hands can no longer function and help them in that way. So then they go to the more advanced technologies of the world using eye gaze technology, head and mouse, or single switches. Lip reading, most important, lip reading, engage with the family and the patient and concentrate and careful listening. Look at their faces, look at their speech, and you will very often be able to understand them. It is difficult, but it takes concentration and very careful listening. Dysphagia. Muscles that coordinate the mechanics of chewing and swallowing may be impaired or non-functional. Ideally, the patient will be evaluated, and as we said before, at our clinic, at every clinic, we have a speech and language pathologist, and they will help determine if the patient is swallowing safely. Very often, the patient will have a swallow study to determine whether they are aspirating or not. Consistencies of liquids and solids may need to be modified. We're constantly working with our patient and families on dietary modifications. Commercial thickeners are available. Pills may need to be crushed and made into a liquid formulation. They are taken with applesauce, yogurt, puddings, or changed to the liquid formulation. Suggest high-calorie foods and not some trendy diet. We try to give safe, very safely studied diets with high calorie, high protein, nutritional supplements to stop or minimize weight loss. Teach your patient how to do safe swallow techniques, and this is taught at the clinic by the speech pathologist, and our support services team reinforces the patients on how to swallow safely to prevent and risk and the risk. Often you will be seeing our patients as they're admitted to hospice programs. Teach your patient how to use their PEG safely. The gastrostomy ideally, the pagogastrostomy ideally is placed prior to hospice admission rather, may be needed to supplement oral intake or need to be used as sole nutrition for patients who are nothing by mouth or NPO. Secretion management, that is the bane of a patient's journey with this disease. Sialorrhea, otherwise known as extraordinary amounts of secretions. Sialorrhea occurs secondary to the weakened oral pharyngeal muscles, resulting in the patient being unable to swallow enough saliva to prevent overflow. And very often families and patients will ask, why are we making so much more secretions, so many more of these secretions? And we say, we unconsciously swallow our secretions all day long. And with this disease, you're no longer able to do that. So it pools and then dribbles out of the mouth. How can this effectively be treated? We treat this with low-dose anticholinergic antidepressants such as Elavil, anticholinergic medications such as transdermal scopolamine patches, use of atropine drops or Robinol, oral suction with a Yankauer. Botox injections into the parotids or the submandibular joints, submandibular glands, are often done before they come to hospice. And this is usually done in the ENT department. Why are secretions so annoying for our family, and why do they feel embarrassed by the patient, by this? Why do the patients feel so embarrassed? Because it can lead to halitosis from the buildup of bacteria. The pooling of saliva may lead to silent aspiration. And very importantly, these patients need very good oral hygiene at least twice a day. So here we're going to offer some solutions to the slippery slope. Finding the balance between drying and over-drying is a great challenge. Thick mucus can accumulate in the back of the throat when the patient has swallowing problems or an ineffective cough. Patients often fear choking on their own secretions. Some of the medications we use to thin these secretions are guaifenesin, otherwise known as Mucinex, and those medications will help prevent nasal drips. Nasal sprays, such as nasocortiflonase. Antihistamines, such as Claritin, Allegra, or Zyrtec. Airway clearance treatments, such as nebulizers, cough assist, help to thin and remove the mucus or the secretions in the upper airways, allowing for greater breathing comfort. Maintaining good hydration and humidity are essential. We recommend using a humidifier next to the patient at all times. Summer, winter, fall, it makes no difference the time of year. So we talked about pseudobulbar affect, or IEED, or involuntary emotional expression. Inappropriate, that can be demonstrated by inappropriate laughter or crying, heightened emotional response. These patients very often have difficulty stopping their laughing or crying, even though they do not feel that associated emotion. Some patients are very embarrassed by this, and others don't seem to mind, especially when their pseudobulbar affect is primarily the giggles. And I have a patient who loves his giggles, drives his daughter crazy, but he thinks it's cute, so he never wanted to take any medication. So the medication for pseudobulbar affect, and you see it advertised on television quite a bit, is called Nudexta, and it's an FDA-approved drug. You often see the advertisements because this side effect, pseudobulbar affect, can be in many other neurological diseases as well as Parkinson's or stroke. Amitriptyline is another drug that can help with pseudobulbar affect. Depression. Very often patients suffer from depression, as with any terminal disease. So a common response for any patient who faces dying of a fatal disease, depression can be a very common response. So we recommend, and very often when they come to hospice, they will already be on antidepressants, and these are very beneficial. But they don't work by themselves. They work along with supportive therapies and intervention provided by social workers, mental health care providers, and spiritual counselors like chaplains. Kindness and understanding from the care team, engaging the patient in conversation and activities when appropriate. And my thing is telling stories, talking and hearing their family stories can very often be how you develop a very close relationship with patients, when you understand where they're coming from. Insomnia is a very common side effect. Try to determine what the possible causes are, and there could be so many possible causes. May be related to just aches and pains because they can't turn on their own. They don't want to disturb their loved ones to be turned. Breathing discomfort, or something as simple as changing the room temperature. Anxiety can be the cause because they're afraid they might not wake up. Depression or fear, or any combination of all of the above. Treat the underlying symptom accordingly, just not a sleeping pill, because all sleeping pills are not appropriate for this patient population. So these recommending a sleeping pill must be recommended with the guidance of the ALS clinic team. Offer relaxation techniques, something as simple as a bedside fan or elevating the head of the bed. Putting a call light within the patient's reach, or something as simple as a portable doorbell or a baby monitor can be very helpful and make the patient feel secure that someone will hear their needs, hear them during the night. A pressure relief mattress, a gel mattress, a low air loss mattress, a back rub, sleeping aid, as we discussed, not every sleeping pill is appropriate, or an anxiolytic, a few kind words of empathy. Care needs need to be taken with sleeping aids, as I've just discussed in depth, to avoid adverse side effects. Constipation. This is commonly a common cause of immobility, decreased activity, changes in the diet, reduced vital capacity, narcotics, and drying agents. So how can we address this? Hydration, 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 whether it's orally with a thickener or through the PEG. PRN medications, as needed medications, or daily or every other day bowel regime may be needed. Consult the dietitian for patients who are still taking their feedings orally, and review the diet, something as simple as increasing their dietary needs. To review enteral formula, something as simple as changing their PEG feeding formula and adding more nutrients or for their patients who are nothing by mouth. So we're now going to talk more in depth about compassionate withdrawal of respiratory support. This is a collaborative effort. The patient, the family, the hospice team, the palliative care team, the ALS Center at Northwestern, or whatever clinic they are attending, respiratory vendors, and the support services team all need to work together to come to a final treatment for these patients. One without the other does not work. The patient can initiate their thoughts and talk about, I can't live with this disease. I can't live with being tethered to my breathing apparatus, my BiPAP, my Astral, my Trilogy. So this becomes a conversation. This is not a quick decision. This is a decision that takes time and everybody in the family on board. And hospice and palliative care are a very important part of this discussion. Very often the patient will say, well, I would like this to be done in the home. We try to discourage that. We try to encourage it to be done at an inpatient unit, in a hospital unit, in the IPU, or a hospice unit in the hospital. But this takes a team, as I said before, it takes a village. We all have the ability at the end of life, at the end of a patient's life, to help them live with dignity, to help them live without pain, to help reduce their fears, to offer a safe and caring environment so that they may die in peace. And we thank you all for listening. and taking the time to learn about caring and helping us care for our pals. And this is very hard work. So here are some of the clinicians' resources: the Les Turner ALS Foundation, ALSA, MDA ALS, ALS Untangled, clinicaltrials.gov, and the Northeast ALS Consortium, which Northwestern is now part of. So today I'm going to close with a famous quote that I'm sure most of you know. So I close in saying, I might have had a bad break, but I have an awful lot to live for. And this famous quote from Lou Gehrig is usually said every 4th of July in every baseball park in the United States. So thank you again from the Les Turner ALS Foundation and Northwestern ALS, Les Turner ALS Center. Thank you for listening.